में मुझे कुछ बंद करना है। तो हट जाएगा ना, ठीक। Good morning. Today we will have a class on malposition and malpresentation. So before starting this, I want to make sure for myself that whether normal presentation is covered or not. So it is done. Normal presentation means cephalic presentation, normal lever. You know anything regarding that? Not sure? Okay. So I will in between I will tell something regarding normal also, so that you will be more oriented towards this. So mal means abnormal, isn't it? So abnormal position or presentation. Position or presentation of what? Fetus. Very good. Position or presentation of the fetus. So here presentation of the fetus, it's correct, but position of not only the fetus, the presenting part of the fetus. Okay, fetus as a whole will have the presentation and will have the position, and the presentation there can be that of the fetal presenting part. Presenting part can be different. It can be the cephalic portion, it can be the breech portion, or it can be in the transverse position. So presentation is a subset of whole of the fetus. Got it? So any confusion between presentation and position? Any confusion? So presentation means it's a part of the fetus. Position means it's a whole of the fetus, whether it is positioned in the cephalic position, transverse position, or breech position. Got it? So, in the subsequent slide, you will be more clear regarding this. So, first thing, there are many abnormal positions in general. So, out of which breech is the most important and also common to discuss. So, in the breech presentation, what happens? The lower pole of the fetus, either in the feet, leg, or buttock, that is occupying the lower pole of the uterus. So that is called as breech presentation. Got it? So not only the buttock, either leg or the foot, anything can occupy the lower pole of the uterus. That is called as breech presentation. So what is the incidence of breech presentation? Here what are the incidence of all the type of presentation? Here one thing is lie. Lie you must be knowing. Lie means how the fetus is positioning in the uterus in relation to the maternal pelvis, in relation to the maternal pelvis and the spine. So longitudinal lie is 99.5%, fetus in longitudinal disposition, and the second one is the transverse, third is oblique and unstable. So this is the commonest, and these three comprises of around 0.5%. So we are more concerned about the presentation and presenting part. So presentation is cephalic, that means the upper part of the head, the vertex, that is occupying the lower pole of the uterus. Then second is breech, lower pole of the uterus, lower pole of the fetus occupying the lower pole of the uterus. Then shoulder. Shoulder means not only the shoulder will be there in the lower part, the shoulder and the lateral part of the body, that will be there in the lower part. So here you can see the incidence. Cephalic is the commonest, that is 96% around. Breech is 3% and other will be there only 0.5%. So, after the completion of this slide, you should be clear regarding the lie, presentation and position. Third one is the presenting part of cephalic presentation. So, cephalic means when head is there in the lower part, it can be presenting in various way depending upon the flexion or extension attitude of the head. So, if head is like this top portion, the vertex will be presenting. So, if it is like this, the brow will be presenting. If it is still like this, the face will be presenting. So, that is why depending upon the flexion or extension of the head, the various other part of the face, various other part of the head that presents at the lower uterine segment. So, vertex presentation 96%, brow 0.5, brow and face both combined will form the 0.5%. What is the predisposing factors for breech presentation? So, as it is a abnormal presentation, we should know what is the abnormality in fetus or mother which may cause the breech presentation. So, first one is the prematurity. When the baby is premature, that means baby is very small. In that case, the relative position, relative space between in the uterus, between the uterine cavity and the fetus is different. That means more amount of space will be there for the fetus to move in. So, more amount of liquor will be there, more amount of fetus, small amount of fetus will be there. So, fetus will frequently move inside. So, that is why there is more chance that fetus may be there in the breech presentation or transverse lie. So, cephalic presentation will be settled as the pregnancy progresses. As the pregnancy progresses, the cephalic presentation will settle. But before that, in early gestational age, all the presentation can be there in equal proportion. So, the incidence of breech presentation increases. You got it? So, prematurity is another a condition. Another extremes of liquor. It's obvious, more the liquor, more space will be there, fetus will move frequently and so the breech chance will be more. Multipetal pregnancy, fetus, there are multiple fetus will be there, they will try to accommodate in a short space, in a very small space. So, whatever space available, they will be presented in that space. Then hydrocephalus, baby's head is very big, so it may not go into the pelvis, it may float around, so it may be breech presentation. Then anencephalus, here you see the anencephalus means when the vertex of the head is not there. So, in that case also there will be no resistance for the movement and fetus may be in the breech presentation. Uterine anomalies like this, if there is any septum there in the upper part. So, in that part fetal position is difficult. So, again fetus will move here and there. Placenta previa, pelvic tumors, prior breech deliveries. These are the conditions in which there is more chances of breech presentation. So, what are the various types of presentation? One is frank breech. Frank means whenever there is extended breech. Here it is extended, here it is extended, sorry, here it is flexed and here it is extended. So, in this position it is called as frank breech. In this position it is called as flexed breech, here flexed and here flexed. So, it is flexed breech and this is footling presentation. So, how to diagnose a breech presentation? So, anything for the diagnosis, first you have to examine, and in examination if it is not sure you have to go for the investigative methods. So, in examination what to do? So, you must be knowing how to examine a pregnant lady, how to examine the obstetric examinations. So, you have to palpate, you have to see, inspect, palpate and auscultate the maternal abdomen. So, in palpation you can see a hard globular structure that is present in the lower part of the body. Sorry, hard globular structure that is present in the upper part of the body. So, head is the hard, globular and ballatable structure. So, ballatable means any structure which can be moved freely from side to side. So, if you hold it and move it, it will move as if you are moving a football. So, if it is moving freely, then that is called as ballatable, and head is hard. So, if hard ballatable structure is there in upper part, then it is head only. So, if head is there in upper part, bridge should be in the lower part. Then again another thing you can see, the fetal limbs will be there in the sides. It can be on the left side or can be right side. How will you feel the bridge? If you try to palpate the bridge, how it will feel? It will be a soft structure, conical structure, not like a globular of the head. So, if it is a soft conical structure, then that is a bridge. So, both you have to check it, head and bridge, to confirm it that it is a bridge presentation, because if you do not see the both the part, it can be a multipetal pregnancy. See, only head if you see in the upper part, it can be a fetus of a twin pregnancy, which is bridge is there in the upper part, and head may be there in upper part also of the other fetus. So, in multiple pregnancy you have to rule out whenever you are seeing bridge in the lower part or head in the upper part. So, here the three things already I have told, frank bridge, flexed bridge, then footling presentation. Then by vaginal examination, how will you assess it whether it is a bridge presentation or not. So, once you have any doubt, if you have any doubt whether it is bridge or not in abdominal examination, you have to go for vaginal examination also. So, there you can see the relation between a soft structure with that of the hard structure. So, here in the face presentation, so it usually confuses with the face presentation, bridge presentation confused with the face presentation, because face structure is also soft and the bridge is also soft. In the face, you can see the nose, you can palpate the nose, you can palpate the mouth, and you can palpate the malar eminences. So, here malar eminences are the firm structure, nose will be a firm structure, and mouth is a soft structure, mouth or lip will be soft structure. So, malar eminences and mouth will be in a triangular disposition, but in buttock what you see, two ischial tuberosities, those will be firm structures, and anus, that is a soft structure. So, it will be in a single line. So, when you try to feel it, if two firm structure and one soft structure in a single line, it is bridge. When it is in the triangular, it is face. Got it? So, again another differentiation we can do it, whether it is a mouth or it is a anus, how will you know it? Because you are not able to see anything, only your finger is palpating whether it is a mouth or it is a anus. So, here you can see in the anus all the structures are soft, it is only muscles, muscle mucosa, everything will be there. In mouth what happens, if you insert the finger, you can see, you can feel the alveolar margin also. So, if in a soft structure around lips will be soft, and still if you go inside, if you palpate it, if you palpate the alveolar margin, then that is mouth only. Got it? It may be appearing like so easy, but it is very difficult to palpate and diagnose with confidence bridge presentation when the patient is in labor, in early labor. Got it? In early labor, head will be slightly down, there may be some caput in cephalic presentation, or there may be some edema around. So, in that case it is very difficult sometimes to diagnose the bridge presentation. So, many things, many approach should be there to diagnose it, otherwise you will make mistake. So, if not possible with the examination only, you can go for ultrasonography. In ultrasonography, confirmation will be there, because you will see directly the bridge there in the lower part. You can detect the anomalies of the fetus or uterus that may be predisposing for the bridge presentation. Other conditions, other parameters also seen, like fetal weight, attitude, all these things you can check it. Then regarding the management, so how to deliver a breech presentation fetus. So it's still a debate is there whether all the breech presentation fetus should be delivered by cesarean section or not. Particularly, these are the conditions, some of their conditions which favors cesarean delivery in breech presentation. Like if the operator is inexperienced for the breech delivery is not as easy as that of the cephalic presentation. If there are lack of experience, then also you can go for cesarean section. Patient requesting for cesarean section, large fetus, and if it is a preterm fetus, then you should go for cesarean section, particularly when fetus is viable, and growth restriction if it is much there, anomalies is present, prior perinatal death is there or birth trauma is there while delivery, then incomplete or footling breast presentation, hyperextended head, pelvic contraction or prior cesarean delivery. In these cases, breech presentation patient should undergo cesarean section. So, particularly in case of preterm, we have to see whether the baby can be salvageable or not. Resuscitation is possible, then in that case go for LACS. If resuscitation is not possible, suppose the pregnant lady with breech presentation came at the gestational age of 23 weeks. So, 23 weeks fetus is not salvageable. So, in that case you go for vaginal delivery. If it is more than 26 weeks, 27, 28 or more than that, in that case go for cesarean section. So, what are the risks of vaginal delivery in cesarean section? So, why you are more in favor of cesarean section in breech presentation? One is umbilical cord prolapse chance will be more, because in head presentation, in cephalic presentation, what happens, the head is completely fitting the lower uterine segment. So, there will be no space around to cord to come down or to prolapse outside the cervix. But in breech presentation, the lower pole is not so well fitting. So, there can be chances of cord prolapse. Second is fracture of humerus, clavicular femur. These are the fracture of the lung bone can occur while breech delivery. I will show the diagrams how the breech delivery occurs. So, you will have a more idea whether there is how the chances of fracture will be there. Then brachial plexus injury chances will be more, injury to the spinal cord vertebra will also be there, and genital and abdominal trauma can also be there. So, labor induction and augmentation, whether should be done or should not be done. So, again there is controversy is there. Still some prefer labor augmentation. If patient has come in labor and it is in the latent labor, you can do the augmentation, but it should be more careful and careful regarding the descent of the head and fetal heart rate abnormalities. So, what is the mechanism of labor in breech presentation? So, here in breech presentation, presenting part is bitrochanteric. Bitrochanteric means the trochanteric, here this one is the presenting part. Presenting part means the part of the presentation which is occupying the lower pole of the uterus, or that is engaging into the pelvis. So, once the bitrochanteric diameter in the oblique plane, it rotates to 1/8 of circle to come into the anterior posterior plane. Oblique plane means if this is the pelvis, if it is plane bitrochanteric is in like this. This is the pelvis, this is in this plane. So, it rotates 1/8 of the cycle, that is the 45 degree, to come into anterior posterior plane. So, whenever it is in anterior posterior plane, in that position only the fetal part usually delivers out of the outlet of the breech. So, it rotates 1/8 the cycle, then the anterior breech, then posterior breech comes out, then posterior shoulder is delivered first because it is a curve is there, then anterior shoulder is delivered, then head borne by the flexion. So, this is the gross steps in which fetus deliver in the breech presentation. but there are many maneuvers, many movements I will show you. So, first thing is vaginal breech delivery can be three types. One is spontaneous breech delivery, one is partial breech extraction, another is total breech extraction. Spontaneous breech delivery means whenever breech delivers, the baby delivers in breech presentation without any assistance of the obstetrician or any caregiver. Partial breech extraction means whenever maternal effort will be there, along with that the obstetrician will assist the breech delivery. In total breech extraction, there will be no assistance, there will be complete extraction by the obstetrician and maternal expulsive effort are not relied upon. You got it? The three methods are there. So, what is the difference or what is the salient points, important points in breech delivery? First thing is that progressively larger and less compressible part are born. In cephalic presentation, what happens? First the firm and larger part comes down, but in breech presentation what happens? The smaller part comes down. So, even if the cervix is partially dilated, the soft part, that is compressed breech, that is the soft part compressed, and that comes out of the cervix. But later on the bigger part that will retain. So, that is the risk of the breech presentation. So, in incomplete with breech presentation, breech may come out with incomplete dilatation. So, if it comes out with incomplete dilatation, there will be more chances of fetal cord compression, because if breech comes out, the cord will be there at the insertion of the umbilicus, that will be compressed. So, that is the risk of breech delivery. So, once cords comes out, it becomes very you have to be very hurried to deliver the whole of the fetus, otherwise cord will be compressed and fetal distress will be there. So, here episiotomy is a mandatory method, because without episiotomy there will be more chance of fetal difficulty in the fetal extraction. Then after breech crosses the introitus, expedited the delivery to prevent the cord compression. You have to maintain flexion of the head throughout the labor process. In cephalic presentation, once the head comes out, you need not worry about the head, but in breech presentation, head comes at the last. So, throughout the journey, you have to maintain the flexion of the head. Otherwise, if head becomes extended, the more diameter of the head will be there, and that has to come through the pelvis, and it will become more difficult. So, spontaneous breech delivery, that is nothing to tell, because it comes out at its own. Main thing you have to describe, understand regarding the partial breech extraction, in which you have to give the assistance. So, once the breech is like this, you have to facilitate the breech to come out. So, but in that case, you need not drag the breech outside. So, only thing is that you have to position the breech in such a way that the back will be anterior. So, always try to keep the back anterior. Then once the breech has come out, then you can deliver the leg by simple flipping it out. So, if this is the leg, put a finger like this and try to abduct it gently, so that there will be no fracture of the limb, because limb bones are very thin at the time, very fragile. So, be careful not to fracture the limb. Here both the leg are delivered like this. Then again you are holding the fetal back and buttock to keep the back anterior. Do not drag it now, as if it is appearing that he or she is dragging it, but do not drag the fetus now. Then wait till the scapula, lower part of the scapula is visible. So, once lower part of the scapula is visible, then you can leave the fetus down, so that it will come still down, or you can have a fundal pressure, so that the head can come down. So, do not pull the head down, do not pull the baby down, because if you pull the baby down, the flexion position will become extended, head will be there inside. If you drag it from inside, the head will become extended. So, always push it from above, do not pull it from down. So, once the nape of the neck comes out, nape of the neck is visible, in that case you have to extend the baby to deliver the head. So, there are three methods of delivering the head that I will show you in the next slides. Okay. So, here delivery of the hand, once the nape of the neck is visible, deliver the hand also by simple hooking method. Here also be careful regarding the not to fracture the humerus. Like this you have to flip it, then deliver the head. So, then delivery of the head can be done by three methods. One is MSB technique, Mauricio Bailey Smith Bailey technique. So, in this technique what you have to do, you have to put your finger below the fetus, that is in the ventral surface, and your two finger will be there on the malar eminences here, like this you have to hold it. Here you can see two fingers will be there on malar eminence. Another hand will be over the shoulder. So, you are holding the fetus like this, and in that case you have to drag it. Why you are holding below? Because this will prevent the head for extension. Head will not be extended if you hold it like this and drag it. So, if you just drag it with the shoulder, head will be extended. So, your hand will be there on the chin, not only chin, on the malar eminence also, to make it flexed, and shoulder will drag it, so that baby will come in a flexed position. Then delivery of the head by the bone muscle method. This is the second method of delivery of the head. Here in breech delivery, it is always difficult to deliver the head. Breech may come out, but head will many times gets entrapped. So, here what I have told, if you just hang the baby down, you should be there, do not hang it and go away. So, the head may come out, okay? Gradually the head may come out. So, coming out means it will not fall down usually. So, once the nape of the neck and slightly occipital area is visible, then elevate the leg. So, the chin, face and nose will gradually deliver. So, this is bone muscle method. Then deliver the head by the forceps. So, this is a obstetric forceps. So, this is a specialized forceps called as Piper forceps. It is having a long shank, this one is a long shank, in which you can hold the fetal head and deliver the baby. So, it is very important both as per your exam purposes there and also clinically. So, if you do not know how to deliver the fetal head in breech presentation, then you will be almost always land in trouble. Then another method is called modified Prague maneuver, that can be done whenever there is face is anterior. That means, if you cannot rotate the baby anteriorly, so in that case by modified Prague maneuver also you can deliver the fetus also. So, this happens whenever suddenly you have seen a patient in breech presentation, already body came out and only head is interrupted. In that case you can do it, but if you are observing from the beginning, always try to rotate it so that back should be anterior. So, here say the same thing, you have to hold the shoulder and gradually elevate it so that the head will deliver. Do not try to pull it outside outrightly, because it will chin will obstruct it. So, if still not possible and cervix is obstructing, you can put an incision over the cervix at 2 o'clock or 10 o'clock, so that the cervix will be little more capacious and the fetus will deliver. So, this incision is called Dora's incision. So, what about the complicated breech delivery? Breech delivery till now what I am showing, it was relatively easy, but complicated means whenever groin is not coming out. So, in that case you have to put your two fingers in between in the groin fold and drag it down. So, this is both groin traction, this is one method. When the leg is not coming down, in that case you can do the Pinard's maneuver. In Pinard maneuver what you have to do, you have to put your finger and push the knee in the popliteal fossa. So, if you push it something here, it will flex. So, if it flexed, then catch hold the ankle and drag it down. Okay. Then third in the last you have to drag it down one leg, then again another leg. Don't drag the single leg to completely deliver the baby. So in that case, the other leg will be extended. So you have to do for the both the leg. So another is lopset maneuver, in which how to deliver the hand. So when the hand is extended, in that case it will be very difficult. You see, if the fetus is like this, so big surface will be there. This much surface cannot come out. So you have to make it flexed. So in lopset maneuver, what you have to do? You have to deliver the hand by rotating it. Got it? So if you rotate it, anterior one is behind the symphysis pubis. If you keep a slight traction and rotate it, the anterior one will come posterior here, and posterior one will come below the symphysis pubis. Symphysis pubis is the point in which it is obstructing. So on rotation, the posterior one will come below the symphysis pubis, so that the posterior one will also deliver easily. So here 180 rotation, then again 180 rotation, like this and like this. Then regarding total breast extraction, in which you have to completely remove the fetus without waiting for maternal efforts. So it is done usually during LACS cesarean section, in which patient will not have any effort and you are having a incision over the uterus, and in advanced labor. So if patient has come in a full dilatation and maybe in distress, or small baby is there, in that case you can put your finger and remove the baby. So what are the practical tips in breech delivery? Breech delivery is very important. You be patients to learn it. You should not be panic. If you become more worried, more stressed, you will try to pull it out. So once you pull it down, you will land in trouble. So don't panic, call for the help, because single person delivering the breech is a difficult task and you may have many mistakes. So another obstetrician should also be there. Always push from above, don't pull from down, keep back anterior. These are the three principles you should observe while breech delivery. Got it? So then face presentation. Face presentation is a relatively rare presentation. So here fetal head and the neck are hyperextended, that is why face is presenting. So here is the lower part of the pelvis, you can see face is down. Occiput comes in contact with the upper back of the fetus. Here the occiput is touching the upper back. Presenting part is the fetal face. So what are the things are there? The orbital ridges, this is the orbital ridge to the chin. The structure between the orbital ridge and chin is the presenting part. Denominator is the mentum. This is the denominator. Denominator means the part of the presenting part which lies in the certain part of the pelvis, so that you can describe the labor process correctly. Got it? The denominator is mentum. So the commonest presentation in face is left mento anterior. This mentum will be in the left side and also on the anterior part of the pelvis. So here which one is left mento anterior? Can you say? So here left mento anterior is there. Is this the left mento anterior? Yes, it is from the lower part. You are seeing the patient from the below. So if you are seeing the from below, this is the left side, this is the mentum. Mentum is anterior and also on the left. It is not in the anterior posterior dimension, it is in the oblique dimension. Okay. So left mento anterior is the commonest. So incidence is around 1:500, common in multipara, because in which abdominal laxity will be there. Usually develop after onset of labor, because with onset of labor, if there is more space will be there and more compression will be there from the upper side due to uterine contraction, head may become extended. So etiology is one, contracted pelvis or CPD, or multiparity, large abdomen, decreased muscle tone, that can cause decreased uterine tone, and in that case there will be chances of extension of the fetal head. So other causes are also there, like nuchal cords. If multiple nuchal cords are there around the neck, so neck will fail to become flexed. If something is there here, it will not become flexed, it will become extended. Fetal thyromegaly, same mechanism. If a big thyroid is there, fetus the head will be extended. Anencephaly region is not known, but in anencephaly also breech presentation is common. So, how to diagnose it? Again by the abdominal palpation, you can see the fetal head or the occiput is more close towards the fetal back. If you palpate it from front, the fetal occiput is more close to the fetal back. So, again vaginal examination, I have already told in the breech presentation, you have to see the triangle in the vaginal examination. Then X-ray, usually nowadays X-ray is not done to diagnose face presentation because you are having ultrasonography. In USG you can see the same thing, head is extended so that it is more close to the fetal back. So, how to now regarding the management? In infant with face presentation, mentum is anterior in 60 to 80% of cases. So, mento anterior is a favorable position and that occurs in 60 to 80% cases. In other presentation like transverse and posterior is in less, around 10 to 12 and 20 to 25% of cases. So, mechanism of labor, fetus with face presentation usually initially begin labor in the brow presentation. Usually it is not so much extended. So, face presentation is the complete extension position like this. So, but in initial part of the labor, it is usually in the brow presentation. Once the uterine contraction starts, it becomes more extended to become the face presentation. So, then the engaging diameter is submentobrachmatic. Submentobrachmatic, this one, this presentation, this diameter is also there in case of cephalic presentation. Here the submentobrachmatic can be the presenting diameter, engaging diameter, or submentovertical. Submentovertical is not shown here, so it can be here to here. So, if it is submentobrachmatic, then this is smaller diameter. So, in that case delivery may be possible. So, this is the mechanism. I will show you in the diagram. So, in mento anterior position, delivery is easy, but mento posterior position, if it is persistent, delivery will be difficult or impossible. So, in mento posterior position, here you can see mentum is in the posterior position, there can be rotation, short rotation 45 degree, then again 45 degree to make it in the oblique position, then again 45 degree to lie it to anterior position. So, total 3/4 of a circle has to be rotated to bring it to the anterior posterior position. Got it? 3/4 of 180 degree. If persistent mento posterior position, mento posterior remains as such, in that case delivery will be almost impossible. So, because the chin and the head will thrust on the abdomen or thrust on the sacral area. So, in that case it is difficult to come out. If it is a very small fetus, it may come out, otherwise it will not come out. So, here the presenting diameter is this one, this is around 18 centimeter. The usually 9.5 centimeter can come out, but 18 centimeter it is almost impossible. So, here the complication is that ill fitting presenting part will be there. So, cord loss will be there, delayed engagement is there. So, there will be prolonged labor. More chances of perineal damage will be there because the larger diameter is coming through the pelvis. Facial edema will be there because the presenting part which is compressed. So, lymphatic outflow will not be there. So, edema will be there. So, in mento anterior, how to deliver? Liberal episiotomy should be given and forceps can be applied if needed. Do not apply forceps in all cases of face presentation. Mento posterior, if rotation occurs, then deliver as mento anterior. If rotation is not there or incomplete rotation, cesarean section should be done. This completes the face presentation. I am having one or two presentation very short only there. Then brow presentation. So, as I have already told, face presentation usually starts with the brow presentation. Here you can see fetal head is slightly extended, but not completely. So, the brow is the this part, forehead part, that is presenting. Incidence is 0.5 to 0.2. It is between full flexion and full extension. Fetal head between the orbital ridge, here the orbital ridge and anterior frontal. This part is presenting, but in face presentation what happened? This orbital ridge to chin, this was presenting. Got it? So, this is an unstable presentation. That means, this presentation may be there in the early part of the gestation, early part of the labor. Later on, it becomes face or cephalic. So, diagnosis by palpation, both occiput and chin, that can be palpated abdominally. So, if you palpate it like this, one side you can feel the chin, other side you can feel the occiput, and both can be felt easily. So, if both are felt easily, then you can suspect that brow presentation may be there. Then in vaginal examination, the sutures you can see, here the frontal suture will be there, then frontanelli, anterofrontanelli, part of the anterofrontanelli can be felt, orbital ridges, eyes and root of the nose can also be felt with difficulty. So, if these things you are feeling, then it can be brow presentation. But if you are able to feel the mouth and chin, in that case it is not brow, it is already face presentation. Got it? So, the engaging diameter is mentovertical, the largest diameter, that is 14 centimeter. Normal size baby and pelvis, no mechanism of labor, you have to go for cesarean section. In persistent brow presentation and particularly whenever it is mento posterior, always go for cesarean section. If it is mento anterior and fetus is small, here you can see this is mento anterior. So, in that case small fetus, big pelvis, vaginal delivery can be possible, but if it is a mento posterior, always go for cesarean section. So, course of labor, it's a transient, maybe correcting to the face or cephalic, already told. If no spontaneous correction, then there can be compression of the submentovertical diameter. Submentovertical diameter, this diameter there will be compression, and this compression will cause fetal distress also. Persistent brow LSS is advised. If it is left as such without doing anything, there can be chances of rupture of uterus. Then the last presentation is the transverse lie. So, transverse lie means when the long axis of the fetus lies perpendicular to the maternal spine. This is the maternal spine, this is the long axis. Incidence is 0.3% only. So, various types are there. Dorso-anterior, with the dorsum of the fetus is anterior. So, here you can see this is which one? This is dorsum. This is what type of presentation? Dorso inferior. Dorso is down. Dorso anterior, dorso posterior, dorso superior and dorso inferior. So, 4 type of presentation can be there in transverse. Dorso anterior is the most common. Etiology similar to that of the breech also sometimes, like prematurity, multiparity, multifetal pregnancy, polyhydramnios and congenital malformation of the uterus. Diagnosis by abdominal examination, you cannot feel anything in the upper part of the uterus and also in the lower part of the uterus, because the upper pole, lower pole will be empty and fetus will be in transverse in the middle. Then head on one side and breech will be on the other side. In vaginal examination, when you put your finger inside, you may not feel anything because lower pole is empty. So, if slight labor has progressed, then you could try to palpate the parts. If palpable, ribs, shoulder and scapula may be felt. Then ultrasonography is the ultimate. By that you can see the fetus in transverse lie. And clinical course, if fetus is very small, usually less than 800, 700, in that case, delivery in doubled position, doubled up position can also be possible. This is the doubled up position. Fetus is doubled up upon its own axis. So this is also called as conduplicato corpore. So this name you have to remember because many times it is asked in the viva. In neglected breech, neglected means breech presentation is there and no intervention is been done. So in that case, obstructed labor will occur, bundle ring formation will occur. The retraction ring will form, hand prolapse can occur and cord prolapse can occur. So in that case, it will be very difficult to deliver the baby even by cesarean section also. So always in breech presentation, don't leave the patient as such. You have to intervene appropriately. So mode of delivery, external cephalic version may be tried in breech presentation. You have to rotate the fetus from externally by both hand method. So nowadays not done so commonly, but it can be tried. But LSCS is preferred in all cases of breech presentation. Dorso anterior and dorso inferior, in that case vertical hysterectomy is usually preferred. In uterus vertical incision should be given because in this case dorso anterior, here you can see this is the dorso anterior. So in dorso anterior, if you put an incision here in the lower segment, you can feel only the back. In back is nothing there to hold it to deliver the fetus. So in that case, if you give a longitudinal incision like this, you can hold limb, upper limb or lower limb and deliver the fetus. But if it is dorso posterior or dorso superior like this, in that case, you can give a transverse incision to catch hold the leg and remove the baby. Got it? So this one is a compound presentation. This is a combination of other presentation. So compound presentation means when one presenting part with another limb. So it can be head with hand, it can be breech with hand, or it can be lower extremity leg with the head also. Many things combination can be there, but commonly head with hand comes out. So management is most cases it can be left as such, so that once the head comes down, the hand will be retracted up. Usually it occurs spontaneously. If not, then you can push the hand slightly off and push the baby from the off, so that head will come down and hand will go up. So this is by push and pull. Sorry, push and push. From below push and push from above to descend the head. So in both cases, perinatal morbidity may increase slightly. Then this is regarding the position. Till now I was discussing about the presentation, abnormal presentations. This is the position which is abnormal, that is occipito-posterior position. So here presentation will be cephalic, but position will be different. The occiput will be in the posterior position. So quickly I will enumerate and I will explain you. It occurs in anthropoid pelvis, deflexed head and abnormal uterine contraction. So diagnosis by the abdominal examination. Here you can see here is the empty part in occipito-posterior. Occiput is posterior, empty part. So abdomen will be seen as a flattening below the umbilicus. So here this part, when you palpate it, it will go down. So it will be flattening. Then vaginal examination, easily you can see you can feel the posterior frontanelli in cephalic presentation, but easily you can feel the anterior frontanelli in occipito-posterior position. So mechanism of labor is, if favorable, then there will be long rotation. So from here, this is the posterior frontanelli, from here it has come to the anterior frontanelli. So it becomes a occipito-anterior position. In unfavorable position, there can be short rotation or non-rotation, or there can be short posterior rotation. So if short posterior rotation occurs, then there will be H2 delivery. So here, if arrest in the occipito-transverse or oblique occipito-posterior position, you can have the choice of vacuum extraction, LACS or manual rotation followed by instrumental delivery. The three are the options. So if it is in the transverse position and arrested, so that is called as deep transverse arrest. In that case, either you have to do the manual rotation or and forceps delivery, or you can have to go to cesarean section. So manual rotation, how to do? If a small baby is there, you can put your finger inside and rotate the head. If the head is little bigger, then you can do the half hand method of rotation. Then short posterior rotation, if there already, as I have told in the flow chart, then face to pelvis delivery will occur. So here in the abnormal presentation, you should have the patience. So if you have patience, you can deliver the bridge presentation very well, because in that case patience is more important, otherwise extension will occur. Swiftness should be there to prevent to deliver the baby whenever there is cord prolapse, and expect the unexpected, particularly in case of shoulder dystocia. So head will come out, but shoulder will be there. So these are the things you have to remember while delivering a abnormal presentation. Thank you. So your first roll number is Adya Raj Sharma, correct? Correct, no? Roll 1, present. 2, 3, 4, 5,